To you. Thanks for joining us on the program Flipside, the other side of the news. You know, the beginning of the month of April there was an international observance for health. It was World Health Day, and the theme was Health for All. But we didn't really do anything special to mark it. But you know, Flipside, which is the other side of the news, it made news, so we need to give enough attention to that discussion. Talking about health is a serious matter. In our 2023 budget, health gets the highest allocation ever, but it still fails to meet the AU commitment. The Federal Ministry of Health got about 1.07 trillion naira as allocation for this year 2023. This amount is 4.93% of the total allocation. But despite this increase, split between 200 million people, which is estimated that we are in Nigeria, it means federal government budgeted 5 naira 4 kobo per person for this year. You know, that's what they budgeted for us. So today on Flipside, our focus is on tackling some of the recent challenges plaguing the health sector. Yes, it's not all bad. I mean, several new vaccines have already been developed. We're talking about the new malaria vaccine, the success of campaigns to eradicate diseases such as smallpox, polio. All this seems likely. New drugs that will be able to massively reduce your chances of getting HIV and all that. So this great news make headlines regularly. But as far as we've come, health still faces major challenges and questions. It's a toxic mix. Problems including inaccessibility of quality healthcare, poor hygiene, corruption, malnutrition, lack of access to safe drinking water, poor health infrastructure, fake drugs, insufficient financial investment, and lack of sufficient health personnel are issues we cannot overlook. These issues have been there. So joining me on the show today to tackling these issues are, seated very farthest from me, Professor Godwin Bazwaye, a face you all know, you've seen on television several times, is currently the CMD of Igbinedion University Teaching Hospital, and he's the one who pioneered the first successful stem cell transplant for the cure of sickle cell disease here. And this happened in 2011. He specializes as a physician, clinical hematologist. Good afternoon, sir.
Thank you, Daisy. Nice to meet you all.
Welcome. And then to sit closest to me is someone you've seen on television several times. And I'm talking about Dr. Leonard Asikidi. Some of you, your brains are already moving. You're wondering the similarity between the names. It's okay. Dr. Leonard Asikidi is the MD Genard Specialist Hospital, and he was the immediate past head of the NHI's UBTH. He's a lecturer, and he specializes in family medicine. He also happens to be my father-in-law.
Thank you.
Good to have you on Flipside today. So we're talking about challenges in the health sector. So I'm going to start with you, Prof. How far so far? How well are we faring? How good is it? How bad is our health sector in an overview?
Well, thank you very much. I'm sure that this question, if you ask even the layman in the streets, the layman will give you the appropriate answer. I think overall, our health sector is not doing well at all. I will even say that we are taking some steps backward compared to what it was before. That's the truth about it. Take, for example, in most teaching hospitals, there are no doctors. And when you have doctors, there are no equipment. So you compare what we had in the past with what we have now, I think in summary, we're not really making progress. We're actually moving backwards. We had thought also too that post-COVID pandemic, that the health sector will have a kind of facelift. Yeah. But you discover that the 500 billion that was budgeted or pumped into to rescue the health sector post-COVID was actually never utilized. There's really no, I mean, you can't see as we in the health sector say that there's a positive impact. So I'll start by saying in summary, we actually not make much progress. We are taught by now we should be doing better things. But generally in the health sector, which everybody knows, and that's how our leaders go out of the country. Because they know definitely that we are not making progress.
Our president-elect just came into the country yesterday. He went to rest, and people were just circulating pictures already that he was going through treatments, but it's looking better. Medical tourism is not something that will change now. But let's talk a little bit about financing. Imagine the federal government looking at Daisy and say, Daisy, all I have for you this year to take care of your health is 5 naira. What's that going to buy? That cannot even buy the cheapest drug for flu, the common catarrh. So I don't know what's going on. Why is financing so poor? And are there ways we can also get private sector to begin to invest into the health sector? Has that ever come into discussions in recent time?
Well, first of all, I actually want to agree with Prof that we have not made any significant progress. If you look at healthcare financing, there are, apart from the federal government budget, there are other, sources of financing. Like the main one we do here is out of pocket, financing. That is, you go to your pharmacy or you go to hospital, you pay from your pocket. The NHIS that we even still have, only about 3% of Nigerians are covered, and it mainly applies to those who work with the federal government. So many states have not even keyed into it. So the major source of financing health in our country is out of pocket. And from the level of poverty we have in our country, that is why you find many people are discharged. They are in hospital for several months until maybe a good Samaritan comes to bail them out. So the source of financing, yes, there are, but the kind of population we have over 200 million persons. So it's like a drop of water in an ocean. So for me, I think the source of health financing, federal government is still playing a very negative role in terms of not meeting up with the 15% as prescribed by the EU. So if there is going to be improvement, government has to really take a decisive action and be deliberate in terms of pumping in more funds to finance our health.
Okay. Thank God you're the immediate past head of NHIS. And many people have tried to key into this program. We've had issues of corruption and so many stories. But what exactly is the problem with this scheme? Why are we not getting more people registered? Even those in the federal sector, federal government's employee, they're still finding it difficult to register.
Yes. Now, you remember there was a time they had crisis at the NHIS where the executive secretary was eventually sacked and we had a new one. The current one, Sambo, I think, has been doing a lot trying to improve on the current NHIS platform. For example, they introduced the gift ship, which is a group individual family social health insurance program. But again, the major challenge, I think, is awareness, because so many of our people are not aware that there is anything like gift ship, that anybody can just come and you key in and they begin to enjoy it. But another major challenge with NHIS are the HMOs. That is the health maintenance organizations. They send patients to you, you treat for several months and even years, they won't pay a dime. And if you rely on that, you discover that the hospital will crumble. So, because before I left NHIS UBTH, they were owing us close to ₦1 billion.
What?
And even when I came in, as NHIS coordinator then, I came in 2019. Some HMOs were owing up to 2016, 2017. From 2017, 2016 to 2019, did not pay the dime. Yet, UBTH, was still taking care of their enrollees. So we have challenges in terms of, one, the people are not aware of some of the packages that are available. Then, two, even with the packages available, you want to enroll, it's supposed to take you an average of 90 days to get your enrollment through. But many a time you can be waiting for over 1 year. And that is as a result of some persons not just doing their job. So there are several other issues plaguing NHIS why our people are not benefiting. State governments are not willing to key in. I know Edo State just started the Edo HIS, which is still again among workers of those state government. So I think we need to reach out more to our communities where my mother and other, others are living. So these are some of the challenges we have with the NHIs.
Okay, Prof.
Yeah.
I know IUTH also has something like the NHIs because I'm a part of that plan or scheme, health scheme. And is it open to all? How does it work?
Well, what we have at IUTH Okada, which we've extended to some establishment, we had a local health insurance program in Okada just because of the farmers or the people living around Okada who are peasant farmers. But that was a temporary plan before Edo-His came on board. So now that Edo-His is on board, we're actually moving to Edo-His because statutorily by the regulation setting up Edo-His, workers are supposed to move to Edo-His. So what my brother Asigide has said is very apt. Now you discover that I'm not too interested more in the budgets that federal government has budgeted for health, because it has always been a big problem. I think the first problem we have in this country is that most of our monies are used to service our politicians. So if you discover that the money used in servicing those in House of Assembly, National Assemblies, House of Reps, Senate, is enormous. So at the end of the day, meeting the 15% we're talking about is going to be impossible. Because these are the guys who make the laws. And they first of all ensure that their pockets are, they take care of themselves before they talk about 15%. So if you get 3%, if you get 5%, you should be happy. Because, so the problem is that health sector can also be removed from the Nigerian society. I think we are plagued with the same problem. Those who are running the health sector in terms of HMOs, as you mentioned, they are Nigerians. And there's so much corruption. The only way to go is insurance for health. Because when you're talking about insurance, you're talking about population. If you have 200 million people, on the average, 25% of them will be ill, and about 10% of them may be admitted. And then when you pull the resources together, monthly, you discover that you have enough funds to actually run the health sector. But the problem is that because of corruption, the HMOs themselves will collect the money, they will not remit it to the hospitals. So it's a complex situation where you're talking about, that's why you cannot separate the health sector from the entire problem in the country. The country is plagued with corruption. People are not sincere. The country is like a joke. We're just moving backwards in every sector. So the only way is insurance, and then two, there's need for public-private partnership. That's the key. So let me give you an example. Most of the teaching hospitals in this country are financed by federal government. Federal government brings money for salaries. But we also know too that federal government was always doing an experiment in Abuja, where one of the government hospitals was giving out as PPP. And then they're making profits. They're also paying salaries. So, but you discover that the system will work better when you have a private person who has his interest at stake and ensures that the work is done. So there's need for insurance. There's need for private-public partnership. This is like a drive. Because why most health sectors are also having problems is that nobody has anything at stake. But if somebody, for example, owns UBTH partly and has 30% at stake in UBTH, you can't come to work and not work. You cannot be loafing around. And you cannot come to work and make patients look miserable. Because the man will sack you because he needs the job done. So proper insurance for healthcare financing and also the plans for a PPP. That is the way to go.
Okay. Now, this also further buttresses the point that government is bad. They are bad business owners. When a business owned by governments, they get it be. But it's okay. Now, let's talk about brain drain a little bit, because this was also flagged as one of the major problems plaguing the health sector. Now, WHO recently brought out a list of 54 countries, and Nigeria, Ghana, Namibia, Zimbabwe, and some other African countries were on that list, saying the number of health professionals we have in our country is too small to take care of the number of people in the country, and as such, they are not going to allow foreign countries take our health professionals as staff. Now, the UK has quickly keyed into this arrangement. For those who are not aware, care workers, doctors, nurses were getting jobs from Nigeria to the UK in the past 2 years, and a lot of our doctors and health professionals have gone to the UK. But now, updates for those who are planning to go. The UK is saying they will not employ anybody from Nigeria again because Nigeria do not have enough health professionals for them to even be raiding our country of the remaining ones. And as such, if you have paid money to travel, you're on your own. So this active recruitment is going to stop. And if there's still going to be any recruitment, it must be government to government arrangements. So if you don't have connection, you cannot also go. So Dr. Asikidi, what do you think about this? How do you feel about this red list that the WHO has brought, Nigeria being a part of it, and what it also means for the young doctors and nurses, health workers who are planning to japa?
Well, to me, I'm not worried. When I say I'm not worried, what I mean is that I think this is just going to be very, very temporary. Because, of course, the UK needs this workforce. And to get to a stage, they can probably go for a short while. Because when you talk about health workers going to the UK and other countries, there are several other countries, that also go to UK. And if you look at the health indices, we are a little bit better than many of them. And again, if you don't go to UK through Nigeria, you can go to UK from Cameroon. You can choose to go to Ghana, spend some time in Ghana, and from Ghana you move to UK. So what I'm saying in essence is that it is not actually going to stop the brain drain. See, in Nigeria, for example, for several years, there have been embargo on employment in all federal government institutions and even states. For example, go across the health facilities in Edo State. A whole general hospital will have just one doctor. That doctor is the gynecologist, is the physician, is medical director, is everything. Whereas there are several young doctors who are there not employed. They are not employed in any government service. They're looking for a job they cannot find. Yet, some people are telling us that they want to make laws to stop people from moving out of Nigeria. Well, maybe we'll get to that. But I want to say that whatever the UK they are saying, nobody is going to wait for any government of Nigeria for them to decide to move. If I want to go to UK today, I may not go through from Nigeria to UK directly. I will look for another route. So, as far as I'm concerned, it was because of the outcry, the false alarm raised by Nigerian leaders that probably necessitated this UK policy. And I know along the line, they will discover that there are doctors in this country that are not gainfully employed. And as time goes on, of course, water will still find its level.
Okay, now, still trying to curb this whole brain drain thing. While they are using theirs abroad, in Nigeria, there was a bill proposed recently for doctors to work for 5 years in Nigeria before they're even giving their license, talk less of moving out of the country. So, as a way to curb brain drain, I will not forget that our minister very recently, last year, said there was no brain drain. That, in fact, what we have is going to become brain gain very soon, and there's a plan. So now there's a bill that has passed second reading, so it's just remaining small thing for it to become law. Yeah. What do you think about this bill, the senators sponsoring it, and how effective will these be in the long run? And should medical professionals fight it?
Well, I still said, this country, we're like jokers. We're just chasing shadows. The real meat of the matter is there, but most times we just play politics with everything. You cannot stop a man who you didn't send to school from deciding what he wants to do. So if you sponsor a medical student to go to medical school, he has graduated, you can decide to bond him. What federal government is trying to do is to bond a doctor for 5 years that federal government did not sponsor for training. So the parents go ahead to sponsor, to look for funds to take their child to school, and then federal government wants to bond the child for 5 years. Even if you pass fourth or whatever reading, but I'm sure that I'm not the president of the Nigerian Medical Association. I'm also not the chairman of the Medical and Dental Council. But those laws do not hold water. Because it's not going to be possible for doctors to wait and allow somebody to come and bond them for 5 years. As I said, we're already chasing shadows. Dr. Asigidi has also said it very clearly. The UK and other foreign bodies are only trying to suit the wounds of our leaders who are just crying that doctors are leaving. Water we find is level. And we've had doctors who have left this country not to go and practice as doctors. They leave this country to go and drive taxis. Some of them leave this country, yes, to go and do other jobs if they've not passed their exam and things like that. Why? I think the main thing is, as I said, stop chasing shadow. Put this country right. These same doctors will come back to the country. At a time when we were growing up, we had doctors from India. We had doctors, foreign doctors, Pakistanis, they were coming to Nigeria. You see, the movement of individuals or doctors will depend on the pay and facilities to work. So if we continue to chase shadow, of course, as I said, UK will say, please, we are not going to recruit doctors and nurses. But doctors can go with any form. And it's just to massage our ego. After some few months, they will continue to do what they are doing. Because if somebody needs a doctor in a hospital in the United Kingdom, and a doctor from Nigeria applies, and the man needs doctors to work in that hospital, you think he will come and tell federal government that this doctor is coming? He will also try to make sure that the doctor finds a way to come over by asking him to pass through. You can declare, say, I'm not a medical doctor, and passes through, and they come, because he needs it. The foreign hospital needs the services of the doctor. So it's a matter of, at a time, most of our consultants, don't forget, this is not the first time we're having massive brain drain. When we were growing up as medical students, we had most of our consultants leave this country to Saudi Arabia.
Yeah.
And it's on department like Ops and Gynae in UBTH, we had only one consultant. At a particular time. But when the country started picking up, these same consultants came back from Saudi. So it's a matter of, water finding its level. So I still say that we should stop chasing shadows. Enacting laws, trying to bond somebody that you didn't sponsor to school, is also illegal on its own part. So I still feel that in respect to that, the only way to stop brain drain, people don't also go to only UK. People go to Ghana. There are many of our colleagues who are in Ghana, Guinea, Tanzania. So they live for anywhere. Anywhere as far as they are concerned may be better than Nigeria. And so they live. So I think it's a matter of facing facts, putting this country right. And once this country is right, these same doctors who hitherto do not like to be slaves, they were forced to become slaves in foreign lands. They prefer to stay home, eat pounded yam, go to the natural environment that we have, eat fresh corn, and do the natural thing we do in Africa. But they are now forced to foreign lands where they are now becoming slaves. So if this country is better, they will come back.
Okay, we hope so, because we're in dire need of doctors. We need them. We're watching Flipside, and we're talking about some of the challenges in recent times that the health sector is facing, and we're looking for ways to tackle them. Well, we'll go on a quick break. When we return, we talk some more. Stay tuned. And of course, you're still watching Flipside. My name is Daisy Leo Asikidi, and joining me on today's conversation is Dr. Leonard Asikidi, and he's the MD of GNAT Specialist Hospital. And I also have Professor Godwin Bazwaye, the CMD, Igbinedion University Teaching Hospital. And we've been talking about some of our problems in the health sector. And I want to move to the next. Although before we went on that break, Dr. Leonard, you said there was something you want to add.
Yes, it's about the law they are trying to make at the National Assembly against doctors, that you, after graduation, 5 years before you get your permanent license to practice. One, First of all, that law is against the act establishing the MDCM. And two, that law is discriminatory because if you look at professionals that are migrating, it's not just doctors. Nurses are there, pharmacists are there, lab scientists, technicians are there, teachers are there. And they are all migrating. Even our politicians are migrating. After most of them, when they finish their tenure, they migrate. Because some of them are not able to survive here because of some of the evil things they've done. They migrate. So, and outside that, their children of the children of these politicians are also migrating. If you take a census of the number of persons in the National Assembly, how many of their children are here? They are also involved in this migration. So if there's going to be any law that is restrictive, it should restrict everybody, including the politicians. And again, to me, it is oppressive. You can't just imagine after graduation, you tell me that I should wait for 5 years before I can get my license. Of course, it's oppressive. And outside oppression, you also discover that you are indirectly encouraging the more experienced hands to leave the country. If I graduate and I spend 5 years, of course I won't be lying down. At that stage, I should be at least a senior registrar or nearly becoming a consultant. And you're indirectly saying that as soon as I become a consultant, it is only then and then alone that I can migrate. So if those people who are proposing those laws are reasonable, I think they should know that this proposal is going to be counterproductive. So, and I would have said we won't bother fighting it, but we will not allow it to stand, because if we allow it, many other oppressive laws will be made by those set of human beings. So we will fight it with everything that we have. We won't allow it to stand. And if it must stand, we will also propose that all these National Assembly members should only go there on part-time, because they are consuming our resources. And that is why this country is bleeding. If they consume about 2/3 of the entire revenue of this nation, you leave 1/3 for 200 million persons. So how do they expect us to survive? So to me, that law, we must fight it with everything that is available to us. If it means going to court, I advise NMA to go to court and challenge them so that we can stop this. Otherwise, they will spread it to affect other persons.
Okay, so I'll just stay with you, Dr. Leonard. You worked with UBTH for a long time before you retired, and there was something I witnessed there. Their story is online, but this one I witnessed firsthand of a woman who was about to have a baby. I don't know what happened, but she lost the child and the woman passed. And before I could blink twice, at that time I was pregnant, I was going for antenatal. So I was able to observe everything. Before we knew what was happening, her family were there and they were fighting with the doctor. It was so rowdy before the security operatives came to try to settle them. Yes, we know a lot of emotional things happen in the hospital. In fact, if you don't get mind, you cannot do their job. It's not for people like us. But what's the plan to curb health workers' abuse in the employ of any government, private establishment, general, health workers' abuse in general? What can we do to curb it, to put a stop to it, and also develop maybe a positive relationship between the public and the health workers?
Well, first of all, I want to tackle this question in this way. Now, what are some of the issues that makes patient relatives lose their mind and begin to attack health workers? Many a time, you discover that patients come to hospital late, and the relatives do not acknowledge this. For example, a patient comes in, and you tell this patient, look, you need surgery. The patient will consult around the entire world, and yet the baby in the womb is dying. Eventually, probably the woman, you successfully deliver that baby, but stillbirth. Different from the scenario you painted. they will also start fighting the health worker. Now, some other issues are, there are several levels of delay of patients accessing care. For example, imagine Benin Auchi Road, that a patient is trapped somewhere at Ewu, and he needed to quickly get even to Irwa, talk less of coming to Benin, and he gets to Eho, he cannot find his way. That patient may even manage to get to the hospital and eventually die because of bad road. So access, delay at, one of the delays is for them to take decision to agree to, first of all, come to hospital. The next delay is for them to be able to access the hospital. And the major problem, the major delay that causes mortality is the delay between taking decision and getting to the hospital. But relatives many times don't want to accept that they cause the problem. They want the doctor to perform the miracle, and so they begin to attack the doctor. First of all, I think we need to do more of education, public enlightenment. For example, you are like this, or this is happening, go to the hospital. I know they exist. Even there is an advert that goes on that says, if you take paracetamol for after 3 days, it doesn't work, go and see the doctor. But they just hear it, it enters from one ear, goes out through the other. So this issue of relatives visiting their anger on health workers, I think it should change. And some of the ways we can curb it, like I said, is educating the public on the need for them to access healthcare early enough. The other thing we can do on our side is to, of course, we have discussed at various levels of NMA. If a patient comes in and is bad, let them know the prognosis from the beginning. Say, look, this case is bad. The patient may or may not survive it. And you carry them along as you are carrying out your treatment. I know that even when you do this, some of them are still violent. And at that stage, of course, the law should take its course. If you attack a doctor who tries to save the life of your relative unjustly, of course, the law should take its course. And that, whoever has done that, to me, should be arrested and, of course, sent to the courts for trial.
Okay, now, you said a lot about public literacy, getting people informed. I had a conversation with my colleague, Adesua Sawageris, and she anchors the Healthy Living Program. Yeah. So she was saying she wanted to do a general test for her body, her heart, her liver, malaria, everything together. I started laughing and said, that's a lot of money. And said someone would do it for 10,000 naira. I said, okay, that's cheap. That's cheap. Okay, but many of us run away from all of these tests. We don't want to hear bad news. We also don't have the means. But then that's for some. Then the larger population don't even know anything. What's contributions? You have a clinic, you're a CMD of a hospital, you've been in the healthcare for a long time. What's your contribution in getting the public enlightened about the need for taking care of themselves?
Okay, I've also said that most times the problem we have in this country cannot be singled out as an entity. It's a complex of so many things. Number one, many Nigerians are very, very poor. So there are two sets of people. There are those who do not have the funds, and there are those who have the funds, but even when they know, they don't want to do it. So that's the first problem. The first problem is funds. You need to, first of all, have the funds. The one that says it's going to do a full walk-off for 10,000, I don't think that's possible. It's not possible anywhere in this country because the naira, the value of the naira is actually not good enough for you to run all the full parameters, maybe even possible look at your x-rays and things like that. So, but the problem is educating the people. There's so much suffering in the land that sometimes people prioritize things in life. You try to prioritize when you wake up, whether this money that I have, do I need to use it to go and do a test to find out whether I'm okay, or whether I should use it first to eat. So those who are poor to start with, even if they are taught, they are educated, they are given all the plus and minus of going to the hospital, they will not, because the funds are not there. That's why insurance does not discriminate. The principle of insurance is that you take bigger money from the bigger people, and then you take small money from the small people. So if you say 2.7%, for example, of basic salary, so somebody who is earning 500,000 pays more.
Equity.
And somebody who is earning 30,000 as a gate man pays less. But the two of them will access the same health care. So if you go to EBT, if EBT is your primary provider, you get there, whether you are the one that is paying 50,000 a month or the one that is paying 2,500, you are supposed to access the same health care. And health insurance also is supposed to have a proviso for having a free medical checkup, maybe yearly, as part of the package. Yes, like what we did in our local health insurance in Okada, you're supposed to have a free medical checkup once in a year. So when you do the basic investigations to assess. So when you have, you see, the beauty about insurance, when somebody knows that I'm paying for my salary, if he has a headache, he will go to the hospital. Some of them, the headache may not even be that much, but they just want to eat part of the insurance they've been paying.
Exactly.
See, I calculate, I don't pay 2,300 every month. And for 6 months, I'm not going to the hospital. Small thing, you say, I want to go to the hospital. That is the beauty of healthcare, of insurance. So when there's insurance, people will have the funds to go. That's for those. That's why I say insurance still remains the major key to providing solutions to all these things. Then two, our establishment should also make it a routine. Now, there are some establishments that employ people without doing medical checkup. So you employ a moving dead man. Yes, a man who has a cardiac problem, you employ him as a security without doing a full medical checkup. Only for 2 or 3 months, the man dies suddenly at the gates. So for this healthcare, the medical checkup, you are supposed to also ensure that every staff that is employed does a medical checkup. So you have that category. Then finally, there are those who have money, can afford the medical checkup, but because of their understanding. And I always tell people, what you are scared of, you don't want to hear today that you have maybe prostate cancer today. If you hear it tomorrow, it's still going to be the same. And then the possibility is that if you hear it today, it will be better to do something about it today than tomorrow. So our fears, that's why the white man is different. The white man goes to the hospital to say, because of knowledge. So I think we need to educate people, but these are the 3 categories of persons.
Okay, so let's jump now to some of our breakthroughs. Recently, there's a vaccine for malaria. It's not new. They've been on it for a long time. But NAFDAC has finally approved one of the vaccines and says this one will be good for us in Nigeria. And we took it on the news. We're happy about it. But I don't know, is it cause for us to be happy? Can we afford this vaccine? By the way, we saw the reaction of people to the COVID-19 vaccine with all the conspiracy theories and the dramas that came with it. Some people are still not vaccinated against COVID-19. So do you think this malaria vaccine is coming to Nigeria to make these ground earth-shattering impacts that we are expecting of it?
Well, to begin from the last part of your question, I think we cannot begin to rejoice so early, because malaria, we know, is not a medical emergency, just like the case of COVID. You know, COVID was a medical emergency. Vaccines were produced in a hurry, and nobody wanted to die, so we accepted the vaccine without the clinical trials. So I don't know how long, whether they did or not. But in this case, I think from what I've read concerning what NAFDAC want to do is they actually want to, again, pass it through the various stages of clinical trials before we begin to key into it. Even if we are keen in, with the cost of each of the vaccines, it's going to be difficult for us to be able to spread it around over 200 million persons, even in a short while. So there are still going to be issues that will probably need to be addressed. Even if they give us for free, there are rules guiding donations, drug donations. If you donate drugs, you must also make provision for logistics. And, you know, it has happened before where some countries donated drugs to our country, Nigeria, and those drugs were allowed to waste because they didn't meet with the guidelines for drug donations. So even if we get free, there are still issues are going to be still going to be there. So for me, we cannot rejoice so early, but it's good news, because if you look at the population of Nigerians that suffer malaria on a yearly basis, that is actually one of the major presentations in our general practice clinic. So I hope and I wish it will actually help us in terms of trying to tackle the problem of malaria. And also, if you also look at the indices, you discover that malaria is one of the greatest killer of under fives. So if it comes through and it becomes useful to us, I think it is actually good news and it's a welcome development.
Okay. All right, now, another issue we have in the health sector is not limited to Nigeria, but I think globally, science is discovery, they taught us. They might be discovering too many things, I would say. Have you heard of cloning? I don't know if that's real, but we've seen it in movies, that they are cloning humans. Now, there's a video I'm going to push play to where we now have an artificial womb facility proposed. And you know, when they start proposing things in the West, they do all they can to bring it into reality. They give nice adverts to it. This facility, they say, is going to help mothers who want to have children but can't have children have the babies they desire. But at the same time, don't forget homosexuality is allowed over there. It means a man can decide to say, today I want a baby, and he will get a baby and become a mommy, but he's a man. And it goes on and on. There's also the womb transplant thing they do now. And there's even a doctor in India who's currently researching on how he can transplant the womb from a woman into a man. So for gay couples who want to naturally have babies, I don't know where the babies will come out from, or they will do CS, but there's just so much. At what point should we draw the line in all of these discoveries and inventions? But let's quickly push play to that Ectolife baby factory facility. And when we come back, we'll just talk about it in general.
Introducing Ectolife, the world's first artificial womb facility, powered entirely by renewable energy. Ectolife allows infertile couple to conceive a baby and become the true biological parents of their own offspring. It's a perfect solution for women who had their uterus surgically removed due to cancer or other complications. With Ectolife, premature births and C-sections will be a thing of the past. Ectolife is designed to help countries that are suffering from severe population decline, including Japan, Bulgaria, South Korea, and many others. The facility features 75 highly equipped labs. Each state-of-the-art lab can accommodate up to 400 growth pods or artificial wombs. Every pod is designed to replicate the exact conditions that exist inside the mother's uterus. A single building can incubate up to 30,000 lab-grown babies per year. Ectolife allows your baby to develop in an infection-free environment. The pods are made of materials that prevent germs from sticking to their surfaces. Every growth pod features sensors that can monitor your baby's vital signs, including heartbeat, temperature, blood pressure, breathing rate, and oxygen saturation. The artificial intelligence-based system also monitors the physical features of your baby and reports any potential genetic abnormalities. The pods are equipped with a screen that displays real-time data on the developmental progress of your baby. These data are sent directly to your phone so you can track your baby's health from the comfort of your zone.
Okay, that's just a clip, a short one. The video is long of everything it can do. You can even decide how you want the baby to be and everything. Sounds very beautiful and nice until they start. Then you start seeing that there are other things that were not told in the adverts for this factory. So, Prof, you just saw that you are doing a lot of scientists. Well, at what point should we draw the line? At what point should we say no? And in Nigeria, is there every of these inventions we are going to accept? You know, we have tradition.
Yeah, thank you very much. Well, the summary is that science usually has no limitation. What any man can think about,
Can create.
most science wants to create it. I will tell you, for example, if you look at even the cell phone, I'm sure if this cell phone was done several years ago, the person will be accused of witchcraft. Okay, you cannot look at a small toy and you are talking to somebody in London and you are seeing the same person. So in summary, science, whatever any man can think about, science wants to achieve it. The issue of cloning, you know, the WHO tries to regulate some of these things. In fact, the first time I did my first stem cell transplant in 2011 at the University of Benin Teaching Hospital, I was besieged by a group of reporters from Abuja and everywhere, accusing me of, you know, cloning. And they thought I was doing cloning. But stem cell transplant, this aspect of hematopoietic transplant, is an approved WHO procedure. So WHO has approval for some of these things. But what we're saying is that science, even the ones that are not approved by science, scientists would usually want to do that. The IVF, when it started, was also something that was a little difficult. And then it was not accepted by WHO until people were doing it secretly. So if we could do an IVF, taking sperm and eggs to make a baby, and then it grows a little before you put it in the womb, now science is thinking, why take it to put in a womb? Why don't you continue to do it in somewhere separate and deliver the baby? So what I'm trying to say in summary is that science does everything. And so we're talking about Nigeria. Yes, we don't do many things or do research in Nigeria. But people leave Nigeria, for example, to India to do some unapproved WHO procedures that are still not approved. We call them, some of them are still under research. But science has a way of doing things that even as we talk, as we are speaking, people are researching on cloning, despite the fact that WHO does not approve cloning. So it's something that is also, as Christians would say, is a sign of the end of time. Because by the time man wants to now start acting like God, then that means there's something that is going on. Then maybe then God himself will say, enough is enough.
Okay.
For us to close the day.
All right. At this point, we're about to end the show. We just have a minute or two to leave the studio. So I'll have your last words on this topic. And in your last words, quickly, in 1 minute each, you can also throw light on how we can be better in preparation for another pandemic, just in case. COVID has come and gone. Who knows what next is coming? Nigeria was able to escape the high death rates. But the next one might just be focusing on Africa. God forbid. I beg, God forbid. Okay, so Dr. Leonard, I'll start with you.
Well, I think the issues we've discussed so far, they are actually the main issues affecting our health sector. And we actually believe that maybe with the coming of a new government, maybe some of the policies may change and favor the populace, especially with the events that accompanied the last election, where surprises were seen all over the place. So, and I also want to appeal to those who are stakeholders in the health sector to ensure that NHI is actually made universal.
Okay. Professor.
Yes, I have always said that without power, you cannot talk about good health care. So this country needs to make sure that there's enough power to run our facilities. Then, as we keep saying, make sure that the insurance policy is properly grounded. With 200 million people, over 200 million people, you can have a very perfect insurance policy. And then finally to say that science will do anything. But as we are saying, we should start from the basics. We're talking about the next pandemic. We were only lucky in COVID because genetically we're black. and we were, you know, protected. If the infection was more affecting blacks, they will not be able to survive it. So our prayer is that, like they wasted the 500 billion as far as I'm concerned was wasted. Let's not waste more money. Let's make our health setup better so that our politicians will stay behind to get treated.
Okay. I want to say thank you to my two very special guests on the show today, Dr. Leonard Asikidi and Professor Godwin Bazwaye, for taking our time out of their busy schedule. These ones are doctors that are practicing. So it's not easy to leave your own clinics and come here, but we appreciate that. And we want everyone to know, my own personal interest is we need to have education. Read something, go online, get information, consult a doctor. Don't be too afraid to see a doctor. Safe towards it, do also towards going to do a checkup at the end of the year. Many issues are coming up. I didn't want to talk about cancer. We didn't have time to talk about cancer, but there are so many problems that people are dealing with today that were not so obvious some 10 years ago. But if we go early enough, early detection is usually better, is key to getting saved. At the end of the day, some will still die, but a lot more people will be alive if they knew early enough what issues they were dealing with. And let the governments put their hands on deck. Private investors come into this matter. Give us money, banks, invest. We need help so that we can all live longer. Our lifespan in Nigeria is dropping every day. I'm Daisy Leo Asikidi. Don't forget there will be a repeat broadcast on GoTV channel 140 and Star Times. And also we'll have the complete video on YouTube for you to watch from any part of the world at any time from this evening. Thanks for your time. I'll be back next week with another topic. Bye.